Hello. When I was a student, actually at high school, I was a trainer of gymnastics. I did gymnastics myself. And I've learned the classic mistake is that if there's noisiness around in your training session, you should not try to shout over it, you just be quiet. It worked again, even here, so that's good. My name is Henkjan Verkade. I'm a pediatric hepatologist and a researcher in Groningen, the Netherlands. And I was asked to present you a little bit, everything about the current prognosis and prospects of liver transplantation. Because as we have learned also yesterday, that's still a major prospect for many patients with these type of diseases. The good thing is, and the bad thing is, we don't have so much specific data on the transplantation in these diseases. I'll tell a little bit at the end. But there was maybe a better interpretation because they're so rare. They're even rare for transplant compared to other diseases for transplant, pediatric transplants. But we thought it may be wise to give you an overview on pediatric transplantation in general and see what you can learn from it. What is the current status and the current prospects of liver transplantation, and also what we still do not know. I've divided it in three. I would like to really go into a little bit into the development, how to get to pediatric liver transplantation. I don't think many people appreciate how recent these possibilities are. I'll show you a little bit on that. I will also then tell you about the current situation regarding indications and prognosis and the unresolved issues, or perhaps better to say, to give hope, the to-be resolved issues at the end. So the development of pediatric liver transplantation, and I'll show you a little bit on worldwide and on our country, because our country, if you ever know where it is, it's very small. It has 18 million, a population of 18 million in the Netherlands, and it has, the good thing is that because of that, well, not because of that, but it certainly helped, we have only one pediatric liver transplantation center, which is our center I'm working in. And that's actually helpful because that prevents low numbers per center, and it also prevents that the knowledge on these rare diseases is also spread out. And it has downsides also, because outside of the center, the knowledge may be actually decreasing. So there's no good or bad. Perhaps, there's always side effects if you centralize. That's what I want to say. So only about 60 years ago, there was the first attempt of liver transplantation by Thomas Starzl in Denver, Colorado. The first ones, actually the adult ones, had been done, they died early on, two of them, the first two actually at the surgical procedure itself. But late 60s, there were the first successes, and actually 10 years later, we had the first liver transplantation in the Netherlands. Still, this was an adult, and only a few years later, we had the first pediatric liver transplant in our center in the country. At that time, our center was one of the first 4 centers in Europe to do pediatric liver transplantation. Well, from then it went quickly. We had the 300th pediatric liver transplant 2007, and actually last Monday we had the 150th living donor living transplantation for a child in our center. So that means in the Netherlands nowadays we have about 140 to 160. Last year we had 180 liver transplants in total in the Netherlands, and 25 or 30 or so are pediatric. Worldwide, I think it's also good to realize, worldwide we have roughly estimated 17,000 liver transplantations per year, counted out per day. It's a massive number. And in Europe, that's about 600 to 700 pediatric liver transplantations in Europe. I think those are numbers actually that you can dwell on also for seeing trends and seeing consequences of the disease and of the treatment. what the major part I derive my results from is from an effort we did with the three of us. Jean de Ville de Goyer, he's a pediatric surgeon, a transplant surgeon. He has been everywhere, but now he's in Palermo, Sicily. Ulrich Baumann, he's a pediatric hepatologist in Hanover. Vincent Caram, he's in Paris, and he is also heavily involved in the European Liver Intestine Transplant Association that actually keeps the registry of all the transplants in Europe. And myself and all the other people are the PIs of the different centers that contributed, and we analyzed the more than 16,000 liver transplantations in children since the start of the program in Europe. So this is quite a number. We did it in two papers. We wrote it down in two papers. This hepatology paper of 2 years ago was mostly on the surgical aspects and the donor and transplant surgery features. And we had another paper just 1.5 years ago in pediatrics that gave more the pediatric aspects, the pediatrician aspects of it. And we included then many of the pediatric leads of the different centers. Oh, sorry about that. This was it. Questions? No. You know everything, do you? I was impressed in the morning, but keeps on going. So this is the pediatric aspect, and for example, we will have Lorenzo Dantiga having a digital talk later on, Anil Dawan from the center that Richard works in. So all of the other pediatric leads were in this paper, and I'll show you some of the results that we encountered. And but if you want to know more, these papers are just available open access, and if you're interested, just check the internet and you can find them yourself. So this is, I think, a busy slide, but it contains a lot of information. I'll show you. On the bottom axis is the years since the start. That was 1968 until 2017. That was the data. We stopped in 2019, but the collection of the European-wide data actually take a few 1 to 3 years. So to have reliable data, we cut it out 2017. It shows, for one thing, that it's only pediatric liver transplantation, which are the bars here, the red, the blue, and the green bars. This is pediatric liver transplantation. It's only about 40 years around that we are actively doing numbers of pediatric liver transplantation. That's still quite new. I think we should, and that's the same situation here in the US. That's one. Secondly, it has climbed. Initially, mostly it was older children, not small children yet. It has climbed to now kind of a steady state, which is about between 600 and 700 patients, pediatric patients per year. That's about 10% of what the adult patients, and adult patients is above 18 years, some countries above 16 years, is about. So pediatrics is about 10% of total of adult patients. What it shows more, actually, I told you we had about 16,000 patients, but you can see it increasing. What we did, actually, we cut the number of 16,000 into 3 eras. The startup phase, initial phase, and then before 2000, then the next decade, 2000 till 2009, and the most recent decade since 2010. And they have now about equal numbers, about 5,000 transplants, pediatric transplants in each era. What it also indicates, this is the percentage of retransplantations. So these are not patients, these are transplants. But initially, about 20 to 25%, it was on the same patients that received 1 or more liver retransplantations. So this illustrates the fact that having once a new organ didn't last for very long. And actually, this has decreased now to below 10%, and actually still declining, although this number is a little bit, we should be cautious here, because, as I said, the latest number may be may still not be completely filled, but still this is now below 10% for sure. So this is quite illustrative, I think. And there's another thing, since ELITA, as it's called, European Liver Intestinal Transplant Association, at this time they started already quite early, but the downside of this is that this is their breakdown of the different diseases, which is not very helpful now anymore. But those are the facts. We don't have more data on that specifically. Congenital biliary, metabolic, ALF is acute liver failure, malignancy, which is pretty clear. But cholestatic and cirrhosis is not always very handy to discriminate between the two and others. But nevertheless, what we can see here is that the indications, lo and behold, and you see the color distribution, have been pretty stable from the beginning. So there is a little bit more malignancies being transplanted as a cause of the transplant, as a reason to transplant. And metabolic diseases is on the rise all over the world, actually. Not just when I was in Japan, the same results, and the UNOS data, same thing as well. UNOS is the US, North America data. What is also interesting to know is, I already said, in the earliest era, before 2000, there was a reluctancy, but also not reluctancy, I would say. It was not the primary goal to transplant small children. And you can see it here. 17% of children below age 1 year, mostly then biliary atresia at that time. But, and it has to do something with the donors that were used at that time. The techniques to split livers or to do a living donor transplantation only appeared later on. And this is still full-size livers, and then the availability of donors was still pretty low, particularly because mostly they needed full-size liver transplants, post-mortem donorship, after death of the donor. And you can clearly see that this has increased. It has about close to doubled since nowadays. It's 30% is below 1 year, but also do realize pediatric liver transplantation is primarily a transplantation of young children. Mind you, this 36 plus 30%, two-thirds are transplant before the age of 6, and only 1/3 for the next 12 years. So again, this is a very early treatment. It's a treatment for young children in general, as number-wise it is. This is actually what is a trend, what I already illustrated. The 3 bars represent again the 3 eras, the early phase, the mid phase, the first decade of the millennium, and since 2010, and you can call this about the present phase, where we are in now, because this is very close to where we are in now. And there are several trends which are easy to see. The blue bar is the full-size graft, the full-size livers that they were started with. We didn't have so much splitting. It only appeared during the era, not before, in the 90s or so. So this actually went down to now about 25% or so. Whereas the living donor liver transplantation has increased massively. It's now 40% in Europe as we speak. It's higher than in the US. It's always been higher, although there are certainly centers in the US who do living donor transplantation as well. It has 2 effects, 2 reasons actually. It's first the techniques developed, and there was a donor shortage, as you have heard, I think, as long as you have been around and have discussed about liver transplantation. There's a donor shortage, and young children can do with segment 2 or 3, the left parts of the liver of an adult, or 2, 3, 4, and within 6 weeks, the donor mass of liver has regained complete normal weight. It's not that the same structure of the liver reappears. I always tend to compare it to a cauliflower. If you take out a cauliflower, you take a branch of the cauliflower, you can use that for a child, and that can grow out. It remains, it has only 1 stem, or 2, whatever you take. The other half of the cauliflower does not get a new branch, but the remaining branch grow out. So you can only do it once. You cannot do it twice. It's not like a salamander. I don't. What's the name in the? You cannot cut the tail twice or 3 times, whatever. No, it's it's only you need the anatomical structure of segment 2-3 or 2-3-4, right? But volume-wise, functionally, the liver regains capacity and volume within about 6 weeks of the donor, and also, as I think it's needless to say here, but to make sure, even if you're transplanted before your first birthday, you can grow old with it and the liver grows with you. The capacity grows with you. It's not that you grow into insufficiency. No, it's there, it grows along with you. That's a very nice feature, of course. So what about, I think, most important things parents would like to know, and I would like to know if I had a child who would need a transplant, what's the prognosis? Where do we go to? This is the historical prognosis. Initially, and this is all transplants of all children, all indications. So this was it was 74% in 5 years survival in the first decade, in the first era. And this at 20 years was 65%. So that means that 2 out of 3 patients were alive 20 years later. This has certainly increased, as you can see. But still, it's not 100%. And that's, I think, we should all realize. There is no free lunch. There's always the risk of mortality in transplantation. It's a big surgery. And still, I always have to tell that to parents and children themselves, that there is this risk. Although the risk has strongly diminished, and particularly also for the indications that we are talking about today, but nevertheless. And the risks are higher, and you may imagine that's the case. These are the data from the last era. Higher if you're transplanted very young. It's below 1 year of age. After 1 year, the 88%. It's not only age, it's only the disease cause, the reason for transplant. And therefore, I think the diseases we are talking about these days are on the better end of the curve. They're about here. But when you are transplanted because of an acute liver failure is a strange disease. It can be caused by many different aspects. For example, we discussed acetaminophen. Intentional or non-intentional ingestion of large amounts of acetaminophen can shut down your liver within days, and you can get into life danger within 3 or 4 or 5 days. And not transplanted, some of them do die. Some regenerate the liver, but this is a cause of acute liver failure. These acute liver failure has a very high mortality, and particularly in the first phase, because not only the liver shuts down, but also the circulation, the kidneys we already discussed. So these patients are transplanted in an extremely poor conditions to start with. So that's the poorest condition, and the second one, or on the rate of survival, and the second one is that you can imagine as well, if you're transplanted for cancer, for whatever reason, it can come back, although we are looking very carefully if there has been metastasis, you still can miss it, and it still can be around, even undetectable for our present techniques, but it can pop up after the transplant, particularly if you give immune suppression, as you may understand. So the diseases like the B-cell deficiency and so on are certainly already here. On the higher end, it already shows that after the first year, there's no major, there's still loss, it's still possible, not major anymore. The biggest issue is here. The surgical and the post-transplant, early post-transplant time is the most risky part after liver transplantation. I'll come back to it shortly. So where are we now? This is the patient survival, but we're also interested in the graft, right? Already indicated if you have a graft, it can grow along with the recipient, but still, how long does it get along? How many of you have asked that question, maybe just principally to your doctor, but certainly also to each other, to yourself, and you're looking around, because we're all interested. I have some good news for you. That's a cliffhanger. Wait. Again, the graft survival has strongly increased for all children transplanted, including acute liver failure, etc. The graft survival has always increased, has continuously increased since the development of liver transplantation, now to about 80%, 5 years graft survival for all children. that are transplanted nowadays, including oncology, including acute liver failure. Mind you, this is 79 or close to 80% now. This is, you can lose your graft by two reasons. It's a little bit blunt, but just how statistics work. It's either that there's mortality by any reason. The child still has the risk to get lost in a car accident or something else, although it's luckily very minor. So this is the combination of death and retransplantation, so that the graft, that the transplanted liver, the originally transplanted liver, does not live longer and needs to be replaced by a second transplantation. So this is a combination of the two. Where are we now in the current situation regarding indications and prognosis? So, as I said, I'm a little bit, I only saw recently that this ellipse was off because I made space for the digital picture, but I forgot to take this one a little bit to here. But if you are creative, it shows where it should be. The living donor liver transplantation has gained very much wind, I think, in the last decades, as I showed you before, for several reasons. Certainly the reason is you can plan the surgery. There's been, what's not in these accounts is waiting list mortality. Waiting list mortality is a big issue. We have analyzed it ourselves in Europe, in Eurotransplant. It had been at times for young children, it had been up to 20% if they are on the list in a poor condition and they're very small. It's difficult to get a graft for them available. It has decreased now to certainly below 5% for the young children, but still it is an issue. And that's never accounted for in post-transplant mortality, because it's the surgery is, of course, the time you start counting, but you don't count until surgery. Well, we do as pediatricians, but that's not accounted for in these type of data. So it has been increased because of to get down in pre-transplant mortality. In our center, that was a major benefit for the child. Now, in our center in the Netherlands, it's very rare to lose a child on the waiting list for transplant. It's actually exceptional now, but it was not exceptional until we actually did a living donor transplantation some more effortly. Nowadays, in our center, 70%, last year 70% of all transplants were living donor liver transplantations. 70%, 70, which is, of course, high. It was also claimed that living donor liver transplantation, particularly if a parent would provide the graft, get surgery and give some segments of the liver to the child, it will be an immunological benefit. That has not been proven so far strongly by the data. Yes, the survival, the graft survival after 1 year for living donor is slightly higher if you're transplanted by a living donor compared to a split graft. A split graft is that you had a graft that was donated after death of the donor, and that was cut to the size that you need for the child. But this goes from 1 year from 80% to 87%, and 5 years from 74% to 80%. So yes, a 6-7 percent difference. But if you were to be transplanted later on, from 1 to 6, 6 to 12, or 10 to 18 years, this is actually much less apparent and not what we call not statistically significant. It can be just chance that there was a child difference in between. So the immunology department that has always been very interested in this living donor relationship, it does not really translate as much to a major big benefit from the one over the other. And perhaps it's due to the fact that even the death donors, post-mortem donation, has been already grown in its quality to a much higher effect than was originally present. Maybe if we have compared this in the first era, it would have been a benefit. But we are now already, the surgeons, the ICUs, the anesthesiologists, they have really pumped up their qualities at several levels. So this is the question you may be interested in, right? How long does a graft last in our child or our patient? I was surprised myself when we got the data, positively surprised. And since then, I've been telling the story a little bit at several occasions. Even people working in the field do not realize how good it is nowadays. That's the cliffhanger, right? So this is, on the horizontal axis, it's in days, it's in days, and on the vertical axis, it's the survival percentage of the graft. It's not of the patient. How long does the graft take so long? And this shows, and it's projected here, this shows of all patients, of all graft types, if you're transplanted above 12 years of age, the 50% of the recipients after 21 years still have the same graft. And if you're transplanted before 12 years of age, after 32 years, 50% of the patients that were transplanted still have their own graft, the first graft that they were transplanted with. So 20 to 30 years. And where is it coming from? Actually, you can see this is still the big leap here. And again, this is including acute liver failure. This is including oncology indications for transplant. So this is even perhaps underestimating for the diseases that we have been discussing these days. And therefore, we looked at the conditional 1-year survival. What's conditional 1-year survival? Conditional 1-year survival, if we take out the first year, maybe the first half year, where the big drop is in the survival. And we start at the first liver transplant anniversary. Yesterday at the zoo, there was the lovely child. Yeah, there she is. Well, she's not listening, right? No, she's busy with important things. Yes. But she had the 5th year's anniversary of the liver transplant. So she should be here now. But so we take at time 0 the 1-year anniversary. And if you go from there, you can see, and we have only data until now, but it's projected also to some extent, it's a kind of a straight line. And the straight line projects until 31 years. So statistically, if your child has the 1-year survival of the graft, there's another 40 years to go that 50% still have the liver, the same liver, or either not the same liver again. That can be that there has been another reason for mortality, or the same reason. It can be liver transplant related, but more likely it's a retransplantation. So 41 years, that's half of a regular lifetime, right? Conventional without disease. I don't know about you, but I was pleasantly surprised by these data. And there's more to go. The graft survival, originally it was stated, and I think it's still a quite common belief, don't put an old liver in a young patient. Particularly that was in the data because we felt, old liver, when I get older, I get more sympathetic what old is, but nevertheless, an old liver above 50 or 60 or 70, should that go into a child? I think you had a short report on a 90-year-old liver in the bilirubin patients a long time ago, right? Hypothetical, yes. Yeah, the paper was, do we want a 92-year-old donor liver into a young child? As far as I know, but there are more experts, there's never been a patient died of old age of the liver, right? The liver is a very strong organ and can regenerate, etc., etc. But still, we feel the age of the donor is very important. But what shows this analysis is something else. The graft survival, according to the age at liver transplantation, seem to be strongly related to the survival of the graft. If you would be transplanted either before 6 years or between 6 and 12 years, so as a child, before the end of childhood age, this is a very shallow decrease per year. And this goes up a little bit between 12 to 18 years or 18 to 45 years, 18 to 45 years. This is the 45 to 60 years, and the older you get, the stronger the slope, the steeper the slope is, which you can imagine because the older you get, you have a higher risk of also other mortality. right? Because graft survival is normal is total mortality of the person, including retransplantation of the graft. So this is quite interesting, and this illustrates, in percentage-wise, the slope. That means how many patients need either die, or the graft either do die or do have a retransplant. This is, in the young age group, it's about 1% per year. So statistically, for your individual child, it can be different. But statistically, of all patients, after 1 year, you have about a 1% risk. Risk is, well, you get it or you don't get it, but the risk on the group size is about 1 to maximum 2% per year of a retransplant. And that next time, it's again 1% about. So which is, I think, a good news. So what does this mean in real life? To bring it home, first, make sure you realize and have a real party, I think, upon reaching the first transplantation anniversary of your child. Do realize that that's a major milestone. If you do reach the first year post-transplant, and you're not on the list for retransplant, of course, you should be reasonably well then. That's, I think, worth a party, and you can do it every year, and you can make it in the zoo if you're the 5th anniversary, but make sure you realize it's a milestone. And second, after the party, the statistical risk of losing the graft is about 1 to 2% per year, which is, I think, lower than many people realize and are fearful of, right? So pediatric liver transplantation has certainly reached a high efficacy as a cure or treatment for severe liver disease in infants and children. But is that all the same? No. I think it should be unfair not to tell that we are not there yet. We have reached major benefits. We have, I think, major accomplishments, and we are happy that that this is teamwork, as you know, from all people around. But there are still things to be resolved. And I'll give you a few at the end of my talk. There's a transplant benefit, survival time for small children. How does that work? Why do younger children have a better benefit than children above 12 years of age? There are reasons to think what's going on. Maybe immunological reasons. When you are still in the womb of your mother, the body already starts recognizing self from non-self, the immune system. And there are indications, if you're transplanted early, that the new organ, which is immunologically different than your original liver, may get more appreciated as being self than as non-self. So you need, for your children transplanted earlier, they need also lower amounts of immune suppression, for example. Secondly, the early post-transplant risks, they're still pretty steep. The first year, you see this big drop. And it's so challenging, and many people are working on it. Can we make that better? Because the big drop is still, and not as much for the regulated type of transplants, but for acute liver failure, for the very small children, etc., etc. We want to do better there with the medical profession as a whole. Transplantation for pruritus versus transplantation for end-stage liver disease. And what is the correct timing of transplantation? So if we now perhaps in the coming years realize that we can set off the pruritus in many children, so what does it mean for the underlying disease? Is still the damage going to be happening to the organ, and still is it only postponing transplantation, or can we actually preventing transplantation? The risk at the transition phase to adult age. Well, most people in the room have transited from the pediatric age to the adult age. And if you do your own mind job, you have not been always too wise with what other people told you. Same holds for when you have a disease. And particularly if you have a disease and you need drugs for it, and you're in such a good conditions that you might think, I don't have a disease. I don't need the drugs anymore. It's a major risk. And we still have only limited capacity to work on that. It's not only the quantity of survival, and I think that's not a difficult statement, but also the quality of survival with a transplanted liver. Now, these numbers are just numbers. But it does depend, of course, what can you do, what can you not do when you have been transplanted. The long-term consequences of immune suppression is an issue. That's known from the adult world that kidney is an issue, kidney function, but also the risks of malignancies, even the simple ones is skin malignancy, but also other malignancies are increased upon long-term immune suppression to some extent. And I'll finish that with recurrence of disease and disease-specific complications. And for example, BSEP deficiency is, as many of you have realized and known, you have this antibody-induced BSEP disease. And as post-transplant, patients may then develop the exact symptoms as before pruritus. So a pruritus with a low gamma-GT cholestasis, which is based on the development of antibodies against the protein that was deficient, non-functional in the original disease, but now in the new graft is coming up, and the body may recognize this as non-self because the body did not have a silencing on this protein because it wasn't there from the beginning. And it's no longer a genetic disease, although the phenotype may be very similar, it's now an immunological disease. And accordingly, the treatment is increasing the immune suppressive treatment. Yesterday there was a discussion which type of mutations are more at risk to get these antibodies. Well, it is again a risk thing, so it's not black and white, but these are several mutations associated with truncated or no BSEP protein expression on immunohistochemistry in the liver and so on. So theoretically, if you don't have the expression of the protein to a decent extent, or a very short fraction only, there is a higher risk that you develop antibodies if you put in the full-length protein via the graft. And we don't know really what's the best treatment. And that's also for the medical community to go further. We in NAPET are aiming to include this in our next workaround for NAPET, because many centers have one or maybe two patients with this disease, but no center has enough patients to really do studies on it, what's the best or not. So we try to do a similar NAPET type effort as we did for surgical barrier diversion and so on, and to work on this. And we proposed this scheme, but we have to admit this scheme has no any evidence behind it. It's just eminence, it's just expert opinion, which is not nothing, but it's not as strong as data. So we work on it, but the principle is, of course, it's an immunological disease, and you need to take away the antibodies and or increase immune suppression. Finally, FIC1 deficiency is not an easy target for transplant because there are many issues, but one of the issues is that post-transplant, the graft is at risk. The graft can get a steatohepatitis type very rapidly. It can an accumulation of fat in the liver, and up to the level that it needs to be transplanted quite rapidly. And secondly, many patients experience diarrhea after transplant. FIC1 is expressed not only in the liver but also in other organs, including the intestine. And upon getting a normal bile acid load into the intestine may express its phenotype, which is diarrhea. So there was a systematic review, and George Vogel from Austria, he analyzed this. This is a manuscript from last year, August. And he demonstrated that the two are actually combined. Patients that develop diarrhea have also a higher risk of developing graft fibrosis. And therefore, originally, I think it was originally done in Japan, the first analysis, but I have to take a rain check. I'm not sure if I'm correctly citing. I thought it was Japan in the first place, but it may be somewhere else, that if you completely take out the bile acids to reach the intestine, it can prevent the diarrhea to a major extent or completely. And it can also improve the damage of the liver of the graft, which has been, of course, very interesting, because now, and this is a poster that was presented, it's not in a manuscript yet, this is a poster of last year at the EASL meeting, again from Vogel from Austria, that if you now take an IBAT inhibitor, ASBT inhibitor, just after transplant, you may prevent or mitigate the severe diarrhea and also the damage of the graft. This is work in progress, as you can indicate, but it illustrates that we need to work on it, and the field is working on it. So, to cap it off, liver transplantation, I think we have seen the development. I tried to picture the development over the years. It's actually still a very recent technique that we now are happy that there's around, because before that life was either fatal or terrible for the patients, I can really tell you, as you may imagine. The current situation illustrates that the graft survival is better than many people expect, but still not good enough, particularly not in the first month after transplant. And we still have work to do, and we will, don't worry. It's a group size effort. This is our team, it's a living donor team, and the transplant team in our university. And actually, it is really, as it is shows, this is a group size effort, and it's always at the edge, not always, but it's serious business. So we do our best, and together I think we can further improve it. And with that, I would like to thank you for your attention.